And then this sleep study by 4 years of age, the reason I put that in bold is because it's a very controversial part of the guideline. Different parts of the country, you can't get a pediatric sleep study. And in fact, we had people yesterday in our medical part of the conference who were from Mexico City. They're doctors in Mexico City. They have no ability to get a sleep study in their whole country. And so they're saying, well, how do we possibly put this guideline into effect? And it is a very controversial part of the guideline. But what we do know is that untreated sleep apnea is not just a noisy person who snores at nighttime. Untreated sleep apnea can lead to higher pressures in the lungs, which is irreversible, meaning that their heart has to pump at a higher strength to get blood to their lungs. And what we do then is if sleep apnea goes untreated for years and years, when the kids get to be teenaged or older, they end up having so much strain on their heart that their heart actually hypertrophies, or what we call, it's like if you every day, kept lifting your barbells and you get big biceps, your heart does the same thing, and the muscle wall gets thicker and thicker and thicker, which makes it harder for there to be space in your heart, for there to be blood actually there, because it's straining so hard to pump, the muscle gets so big in your heart. And then that pulmonary high blood pressure can be irreversible in their lungs. At the same time, that strain on the heart, especially if your child had heart issues already, can also be difficult on their heart as well. But beyond even the heart and the lung issues, which I think is probably one of the most important things, there's behavioral developmental issues that go along with sleep apnea if it goes untreated. So we have a lot of kids who come into the center, and we haven't seen them before, and they get diagnosed with ADHD somewhere else, and then they come to see us, and we find out that they have florid sleep apnea. And then once that sleep apnea is addressed by an ear, nose, and throat, usually the first step is tonsils and adenoid removal. Once that's addressed effectively, a lot of what's called ADHD goes away. And I think that's an important thing for families to realize, is that we don't necessarily give sleep apnea the credit that it needs to be given a lot of times as far as being able to cause other features, chronic headaches, daytime sleepiness. Imagine going to work every day and being exhausted, because even though it looks like your child is sleeping, their brain is constantly waking up to remind them to breathe. And so they're not really getting full sleep, so they go to school sleepy, so they don't do as well in school as they could. And I think so sleep apnea is something that I really make sure that we get addressed as best as we can. In Pittsburgh, we're able to do that because we have a pediatric center, but I do appreciate that it may not be as available locally from where you are. But it might be something to think about. If you haven't had something like that done and your child is around 4 or older than 4 and hasn't had it done yet, it might be something to think about trying to obtain somewhere that can do that for you. And then, as far as upper respiratory tract infections go, I really want to make sure that pediatricians in the area and parents as well know that we shouldn't just automatically give antibiotics at the first sign of runny nose for everybody with Down syndrome. Yes, they get more sinus infections. Yes, they get more colds. But if we give everybody antibiotics every time they get a runny nose, what we end up getting is a lot of resistant bacteria in that child. And then when they really do need an antibiotic, it doesn't work quite as well. And so we want to be judicious in our use. Not meaning we shouldn't use antibiotics, but we should really make sure that our pediatrician has ruled out the possibility that this might just be a virus that won't respond to antibiotics before we give them antibiotics at the first sign of runny nose. Okay. As far as eye issues go, I'm not going to go through each and every one of these issues, but eye issues are more common in Down syndrome, and because of that, it's really important for them to see a pediatric ophthalmologist pretty soon after they're born. We usually do it at about 6 months of age that we want them to see an eye doctor. And the reason is what your pediatrician can see in the office, or your family doctor can see in the office with the ophthalmoscope, is nothing compared to what an ophthalmologist can see with their equipment. And issues can be dealt with much better when they're caught early. Things like cataracts and high eye pressures and all that type of stuff that happen more common in Down syndrome. If we catch those things early, can almost be a non-issue if they get managed early as well. So we like to have the kids seen, and this is the schedule I put here on the slide, in the first 6 months of life, and then every year from the ages 1 through 5, every 2 years until they're 13, and then every 3 years, really through adulthood, they should be seen by an ophthalmologist. Now, if the ophthalmologists say, no, we need to see your child every year, we'll see them more frequently than what these guidelines say. These are minimal. At least this many amount of time they should see an eye doctor. Endocrine issues, which is your hormonal type of things. Thyroid is the thing that's most common in Down syndrome. About 20% children and adults with Down syndrome will develop hypothyroidism, and they can be born with it about 1% of the time. That's congenital. They can be born with it about 1% of the time, which is 30 to 40 times the rate of the general population. So babies, we really want to make sure that they have their thyroid screened early in life, because thyroid has a big role in our development of our brains. And so, especially as babies, it's very important for them to get their thyroid screened early and often. And you can acquire thyroid disease at any point in the lifespan. So even as adults, it's very important for people with Down syndrome to get their thyroid screened at least once a year. And there's this entity that is very... we kind of think it's a pre-hypothyroidism. It's called subclinical hypothyroidism. So we check two numbers when we're checking thyroid. TSH is kind of like our thermostat. Our brain tells our thyroid using TSH to make thyroid hormone. And then free T4 is that actual thyroid hormone in our blood. So people with this subclinical hypothyroidism, their thermostat is really revved up, trying to tell their thyroid to make more thyroid hormone. And it takes that revved up amount of TSH just to give them a normal free T4 level. So we think that they're probably going to be headed towards hypothyroidism at some point, and so we screen those people more frequently as well. Hyperthyroidism, or overactive thyroid, is actually more common in Down syndrome as well, and so something that we also, as part of our screening, we'll be checking for that as well. Diabetes, especially type 1 diabetes, can happen more frequently in people with Down syndrome. Type 1 is what we used to call juvenile diabetes, but really it can happen at any point in the lifespan. It's where their body actually makes an immune response against their pancreas gland. And so they're not able to make insulin like everybody else does. Type 2 diabetes, which is the obesity-related diabetes, happens a little bit more frequently as the kids get older and become adults, because obesity becomes more of a problem in our population, as you well know. And so it's important for us to keep their weight as ideal as possible to reduce that risk of preventable diabetes or type 2 diabetes. And then growth hormone deficiency is listed as a possibility in Down syndrome. We really don't see it very frequently, but it is something that we think about. So the thyroid screening, we check across the country on the newborn screening. So if your baby is born in a hospital, they had their thyroid screened as a baby. And then we check them again at 6 months of age, again at a year of age, and then annually for the rest of their life. They should be checked for their thyroid. And the next topic is the hematologic issue. And this is the one where most families have the most amount of anxiety when it comes to Down syndrome, because they've read about the chances of leukemia. Leukemia happens in about 1% of people with Down syndrome, so about 1 in 100. That means 99 out of 100 people with Down syndrome never get leukemia. So that's, you can spin statistics one way or the other, but I think it's important for families to know that it is not the majority of people with Down syndrome who develop leukemia. In fact, it's a small number. When you compare it to the general population, that's 0.1% of people in the general population will get leukemia, or 1 in 1,000. So it's definitely more common than in the general population, but never the majority. Then there's this strange condition that happens in newborns with Down syndrome called transient myeloproliferative disorder. About 10% of newborns with Down syndrome are actually born with leukemia. When you check their blood count when they're first born, they have all kinds of leukemic cells in their body. And then in about 3 months of life, they're all gone. And no treatment happens between then and 3 months, but it goes away. And nobody really knows what causes it, but we do know that people with this transient myeloproliferative disorder, or TMD, they do develop leukemia at about 30%. So instead of 1%, it's 30%. So if the baby has that, they really need to be screened for leukemia more frequently than other kids. So all babies with Down syndrome should have a screening, what we call CBC, or complete blood count, at birth to look for that TMD, or transient myeloproliferative disorder. And of course, if there's something abnormal, they need to see the hematologist at that point. And then iron deficiency is more common in people with Down syndrome, and so every year they should have a screening for iron deficiency as part of the guidelines. And the reason for that, I think, is multiple. One is that the diet tends to be a little bit more picky in people with Down syndrome, like we talked about. So iron-containing foods tend to be green, and green is a color that many of my friends with Down syndrome try to avoid. And I don't have Down syndrome, as you can imagine, but I also try to avoid green. Maybe it's because my brother and I avoided it together. I don't know. But green is where we find iron, and also meat or textured types food tend to have iron in it, and a lot of my friends with Down syndrome don't like textured foods. And so iron deficiency then becomes more common. And then milk, an over-excess of milk actually increases your risk of iron deficiency. And we have a lot of milkaholics in my clinic as well. They drink a lot of milk. Really, kids should be, and people in general, should be limited to no more than 16 to 20 ounces of milk a day, because more than that actually increases your risk of iron deficiency. Now that does not include formula. Your babies formula is fortified with iron, but cow's milk or whole milk or whatever you give your kids after they turn 1 is not very high in iron, at least absorbable iron, and so it's something that we need to be aware of and we need to screen for to make sure that they don't need extra iron supplementation. Immunologically, kids and people with Down syndrome in general really have immune issues that kind of are on both sides of the spectrum. So the immune system tends to be not as good at fighting off infections. So kids and people with Down syndrome tend to get more infections than you would expect. They get more sinus infections, ear infections, and we talked about how the anatomy plays a role in that, but also their immune system does not have the same amount of antibody levels as our immune system would. So if we check their antibody levels and their T cell levels and all that kind of stuff, when we check them, they're lower than you would see in other kids and other adults their age. And nobody really knows why. So they have an underactive immune system, while at the same time having an overactive autoimmune system. What that means is that anything where your body could potentially fight itself, its own immune system fighting itself, happens more commonly in people with Down syndrome. We talked about a couple of them already. Acquired hypothyroidism, which is called Hashimoto thyroiditis, or it's an autoimmune attack on your thyroid gland. We talked about type 1 diabetes, the autoimmune attack on your pancreas. They can have what's called vitiligo, which is an autoimmune attack on your skin cells, where they might have a little bit of white patches on their skin. They can have what's called alopecia, where they get circular hair loss on their body, or really they can have alopecia of their whole body, meaning they have no hair growth on their whole body. That is an autoimmune condition. They can have a higher incidence of arthritis, juvenile arthritis, which is an autoimmune condition. So it's very strange. Underactive in some areas, overactive in others. So we always have our eyes peeled for these types of autoimmune conditions in the kids that we follow in the center. Plagiocephaly, which is this child, you can see kind of a flattening of the head here on that one side. Because of the lower tone and the developmental issues, many of the babies that we follow in clinic spend a lot of time on their back, longer than the other kids. Maybe they're the same age, they might not be rolling over quite as early. They may not be getting off the back of their head, so they get a flattening on that side of the head. So we watch that very closely, because if that doesn't get better with just simple repositioning techniques, it can lead to tightening of their neck, so they're always kind of looking towards one way and they have a hard time turning their head the other way. Of course, that's a big problem. It's what we call torticollis. And so many of the children end up having to get referred on for what we call helmet therapy. This child does not have Down syndrome. He's actually my nephew. But I like his Bears helmet, and so I include him in my talk. But yeah, this is that helmet that they put on the head to kind of remold, reshape the head. And so that's the plagiocephaly. Orthopedic-related concerns. A lot of the kids can have what's called ankle hyperpronation because of the hypotonia of the ankle, and all of the weight ends up, for all of us, on our ankle joint. And because of the lower tone in the ankle joint, they can sometimes evert out their foot. I'm sure some of you have seen that in your children or friends with Down syndrome. And so sometimes what we do is we put the kids in orthotics, not because it corrects this problem permanently, but because it helps them to get stability to their ankle. And they sell these in all sizes. They go up to adult ages. And what this does is it just gives them that extra stability, because if your ankles are always everted, you're putting more stress on your knees, which are going to give you knee pain, which puts more stress on your hips, which will give them hip pain. And in fact, I've had one child who came in because of back pain, and when we put her in orthotics, her back pain got better over time. And a lot of the times the endurance issues, as he gets older, he doesn't want to walk anymore as far as he used to walk and things of that nature. Putting them in orthotics actually helps them with their endurance as well, because it helps them to be able to handle those longer walks and things of that nature. Patellar dislocation, we all have a kneecap. Our kneecap is usually held in place by our patellar ligament, but that can be a little bit hypotonic in people with Down syndrome. And so we have some kids who like to irritate their moms and dads by pulling their kneecap off and making the snapping noise and whatnot, which, can be a little bit irritating. It doesn't usually cause long-term consequence, but of course if they're having permanent dislocation to their kneecap and they can't get it over, we send them to orthopedics, and orthopedic people do what they do, which is they pull out their drills and screws and they fix it. But otherwise, if it doesn't cause them any pain or difficulty, we just tell the family, just ignore it, and then maybe they'll stop doing the subluxation. But it doesn't cause them any long-term consequence generally.